Thank you for inviting me. I am trained as a medical doctor, and some technical terms doesn't sound too familiar for me. My task is now to summarize 20-year work in 10 minutes, so I try. This is the basic e-prescription, which is our aim, and we are in piloting phase and small field phase of that. So this is just to show you how the story goes. So the physician prescribes the medicine, the prescription goes to servers, the servers store these prescriptions, and when the patient appears to one pharmacy, identifies himself, then the prescription goes down to that pharmacy. That's the basic of this e-prescription. This is just to get familiar with the drawing. Okay. There were many questions about coding, and when you have an e-prescription, the first question is coding of each information in the prescription. So the problem is there are no international or European-wide codes. So if I could have one wish, my wish would be codes, please. Codes for drugs, codes for diseases, codes for pathology, and so on and so on. So what we use now is ATC, which is incomplete. It was originally designed for utilization purposes, not scientific purposes, not e-prescription. It's not detailed enough. ICD-10, also not detailed enough. There are no levels of the disease, no stages of the disease in many times, and so on. European standards for e-prescription are so insufficient, and there is an e-SPC project going on, and I copied out from the e-SPC website these two sentences. Please think about it. When the doctor writes an e-prescription, it goes to national level, it goes to another country, and it goes to the pharmacy where the patient presents himself. Okay, the doctor is responsible for prescribing a medicine which is out there in Portugal. So I am responsible in Hungary to prescribe a medicine which exists in Portugal. How do I know it? When the patient presents in Portugal with a receipt, an electronic receipt there, which is probably not available in the country, that's what the text says, then the pharmacist can decide whether he can substitute it or not with an existing product, or doesn't dispense at all, which is in the case of insulin, it's a problem. Okay, what we did for the first 10 years of our life, of our company life, was giving information for all points of care. This was a web-based technology. We were receiving questions about medicines and returned answers. We focused on all kinds of dangers. So a safety check was done for all levels. This was interactions for drug-drug interactions, drug-herb interactions, drug-food interactions, allergies, cross-allergies, and intolerances like lactose. It's an intolerance, it's not an allergy. The pregnancy, breastfeeding, dosing, contraindication by ICD-10. We have at least ICD-10, so there is a possibility of contraindication. We cannot tell it for sure. Just give an automatic warning that it may be a problem. Okay, we had a several level warning system. The first three is used for contraindications. The first is life-threatening contraindication. Okay, if somebody has a contraindication and the medicine won't work, it's not usually a life-threatening event. The second is that the contraindication when a doctor must do something if he gives these two drugs together. There are that kind of contraindications. The third is the normal contraindication. The fourth is the warning and action required again from the doctor. He is responsible for doing something if these two drugs given together, for example, or an existing disease. He must do something when he gives this medicine. Okay, there are the warnings, and there are don't care about it warnings, like the stool becomes more brown. Okay, it's not important medical. So when we got in deeper, we went into pharmacogenetics, which again, it's a new field, and we find out more and more. But when you think about it, there are the parallel interactions when one substance makes the other substance more toxic, the other rises its blood level. Then the interaction is more potent than any of each one. And also the timing, if it's a chelation, it's 3 hours. If it's an inhibition, it's 1 week. If it's an induction of an enzyme, it's 2 weeks. So how to display? Okay, colors and text, numbers, warning numbers. Okay, 1 is the most important, 7 is less important. There can be automated generated short text. A doctor has a few seconds of making a decision about a prescription. Within a few seconds, he won't go through the SPC and find out where it is. So we give a short sentence, this blood level rises. Okay, and the third is naturally all the SPCs, for example, 2 or 3 drug SPCs, and can be linked to the full text of science. The doctor should be interested about the prices as well. So we display the price level of generics, the cheapest, middle level, and most expensive drugs of the same generic 10 milligrams of amlodipine this time. You see all that is 10 milligram amlodipines, and you see the price levels. So when the doctors began prescribing, we asked the pharmacy about the availability of the drugs and also about the prices of the drugs. So we can ask for a specific product, and we can ask by ATC code level. Like we want an enalapril prescribed, whatever it is, he will choose in the end. And also we can make alternatives. So if one original substance or drug is not available in the pharmacy, we can show alternatives, and we can also show OTC drugs which are compatible with that original prescribed drug. How it looks like? Here is the original prescribed drug is available in one pharmacy. There are other pharmacies which says I can order it and the patient will get it for tomorrow. There are the alternatives that they are equal drugs. There are some on stock. If there is nothing information, here is the phone number of the pharmacy. These are all about the nearby pharmacies. These are ATC substitutes for the drugs, and there are OTC and medical device. For example, if antihypertensive drug is prescribed, then a blood pressure monitor can be recommended for the patient to buy. Okay, that can be combined with home delivery. If the patient and the doctor knows which product in which pharmacy he wants to order, he can order at the doctor a home delivery. So the order must be signed by the patient, and the e-prescription can go this time to a chosen pharmacy. The patient don't have to go there. The prescription goes there automatically. At the end, the drug can be home delivered. So the last time is we connect the patient together. The patient can have a personal health record where a copy of the e-prescription can go inside into her personal health record. And then he can make checks for the foods, for example, he is going to eat, because the doctor doesn't know about the foods and the grapefruit juice he wants to drink or not. And can be reminders also on his mobile phone, please take your medicine, it's time to go for a refill. So that's where we stand now, and really thank you for your attention.
Thank you very much for this nice presentation on the power, the information, and linkage with different ICT tools. This is open for question, discussions, and when we go to lunch. I could start and ask you, it's a lot of precise information you have here, and I wonder how can you keep it updated? It's a lot of things that needs to be correct. So that's one question you could think about. And then I hand over to Brian Goodman.
I must admit it's hard work. We have many automated systems, like taking all the SPCs from EMA website automatically, and automatically search for differences between the text, and then it's human power to make a decision whether it's medically important and should be incorporated in the automated knowledge base or not. There are a lot of automation, but manpower is still always needed.
Please.
Thank you very much for your nice presentation. Two things come to mind and build on what Lars has said. Is firstly, who will own the content of the e-SPCs? Because what we do see is different variation across different countries in terms of how to interpret it and give that information to the doctors. That's one. Secondly, I know we've heard a lot about prices, but my understanding is that the EMEA doesn't really discuss cost efficiency, if you like. It's more looking at efficacy, safety, and adverse reactions. And I know from the work that I do across generics that generic prices can vary, say, 36-fold across Europe. So perhaps in this situation, we shouldn't be looking less at prices. We're looking at sort of standardization of the clinical data across countries.
I have only thought about who owns the SPCs. I think both parties, first the producer of the drug who submitted it, I think that's the main owner. The second one is who authorized it, that is EMEA. The second is, my presentation was what kind of information can be needed at the time of e-prescription. And in that way, price is an important information. Okay, what I haven't talked about, which is another question, this is national guidelines and financing guidelines for different diseases and use of medication. And also there can be the National Health Insurance Fund can have regulations also how to use medicine. When prescribing a medicine, this is an essential information as well.
Thank you. Eisler, and then the last comment from Steinar Madsen.
Could you please confirm or refute my impression that I had? You say there are contraindications, interactions, etc., that are more important than others.
Sure.
Nobody doubts that. And I'm keenly aware that sometimes we don't rank in the official SPC, we don't rank those. So what you're saying is you take it on yourself to say this one is a level 8 or whatever levels you had, and this is a level 1. Is that correct?
Yes.
I mean, a personal question would be, you're taking on a lot of responsibility.
I do. I am a medical doctor. All the minutes I am working, I take responsibilities.
That's a very honest answer.
Okay, I think it's an important question for the rest of the day. Steinar Madsen has the last words.
It's a little comment from Norway because we are implementing e-prescription on a national scale from 2013. Everyone will do it then. And we'll also launch generic prescription totally. We're changing from name prescription to generic prescriptions. And the problem is then we have a lot of e-SPCs, but we don't need them. We need one generic e-SPC. And that is one of the biggest problems that we have. Because we should have the standard e-SPC, and that is, of course, a problem with authorities because we recognize the individual drugs, but what we should have is generic e-SPC.
There is also just one comment on that. Even a generic can have a special indication, which was submitted by only that drug, and that is protected, as far as I know well, is for 5 years. So he may have an advantage in one indication. So this makes a life a bit more complicated.
Okay. Thank you very much. I think we have had a great session and very nice presentations.